Hi. Okay, today we're going to talk about hemolytic disease of the newborn. We did some research and we just want to show the importance of genotyping, a new procedure or less practiced procedure in order to identify antigens. And right now we're using routine serological procedures to identify antibodies or antigens rather, and hemolytic disease is based off of antigen D. Basically, the mother is going to be D negative and her child is going to be D positive. Now, when that situation occurs, the mother is going to make antibodies to the antigen D that is carried by the fetus. It's kind of illustrated here where the fetus is carrying a D antigen and the mother is negative. So what will happen is those cells that has the D antigen on it will start pushing out of the placenta and carry it over into the mother. The mother is going to respond and make antibodies. So those antibodies attack anything that has a antigen D on it. And in this situation, the infants or the fetus red blood cells. So the baby is at risk of mental retardation, cardiac failure, or just it could be fatal, as in death. And we want to do our best to try to prevent that. So routinely what we're doing right here is we're using serological methods. And what I want to do is just show you that we need to switch over to using genotyping, because genotyping is going to be more cost effective, it's going to be more reliable, and it's just going to be increasing patient care and decreasing the chances of getting hemolytic disease of the newborn towards the child. So basically what we did, we took a look at demographics and we saw that hemolytic disease of the newborn is more prevalent in the African American population, followed by the Asian population, and you see it less in the European population. But nonetheless, you don't want to put your child at risk for hemolytic disease of the newborn. And right now, as I said before, serological procedures are what are used currently, and we want to try to make the switch over because it's just better. And the thing about it is they're using genotyping with cystic fibrosis, they're using it with PKU, and they're using it with acyl-CoA dehydrogenase deficiency. So there is, if they're using it for those three aspects, why not use it for hemolytic disease of the newborn? You know, I think it's very important because, I mean, look at the results if hemolytic disease of the newborn occurred. Like I said, your child could die, your child could be living lifelong with mental retardation, and your child could experience cardiac failure. I think it's worth it to try to switch over. If you can use it for other healthcare purposes, why not use it for, you know, things that are related to the child? So what we did with our methods, we used a quasi-experimental design, we used automated testing systems, and we use the systems to amplify the exons and the mutation sites just on the weak D or the D antigen, just to increase the possibility that we can identify these weak D. And weak D has to do with the expression of the D antigen. Serological methods are not as good at detecting weak D because weak D is not being expressed at a high enough level to where current serological methods can detect it. But this is where the genotyping comes into play. The genotyping is much more efficient using PCR to identify, for example, antigen, antibodies, KID, for example, genotyping. And as you can see the bands, and that's how they use it. But basically all we did is we took 1,000 donor units over a span of 6 months, and we found that 0.21% of those units that were originally issued as D negative were found to be D positive. They were weak D positive, and they were only identified because of genotyping. So what we want to do is take those units that were identified as weak D positive and reissue them into inventory with all the rest of the weak D or antigen D positive units. That way they will not be, when it's time for transfusion during delivery, those donor units will not be issued to a D negative female, and as a result, her making antibodies to the antigen D. So, in all, this will reduce chances of hemolytic disease of the newborn. In conclusion, basically, why not use genotyping? There's a facility, the Blood Center of Wisconsin. The Blood Center of Wisconsin is, they have had 16 years of experience with using genotyping. And according to this Blood Center in Wisconsin, you're going to increase patient care because you're able to identify this antigen D more efficiently, and you're going to decrease costs, and everything comes down to money. So, and it's a rapid turnaround time. But if you're going to decrease costs, you're going to increase patient care, and you're going to basically, it's just going to be cost efficient. Why not switch over to genotyping? And that is pretty much the gist of things. Let's see some of the things that I may have left out. If it ever got to the point where the female did come over to or there's a situation where there was incompatibility, some methods that you could use is, as they're already using, they're using RhoGAM. RhoGAM is issued to a female at like 22 weeks of pregnancy, and what it does is it suppresses the immune system. So if antigen D is introduced into the female's body, her immune system doesn't respond as intensely as she would without it. So that's one method that they're using in situations where a D negative female is introduced to antigens via incompatible donor units, or the baby is carrying D antigens. So what we want to do is just prevent all of that from even happening with genotyping. Thank you.